Well, Dr. Applegate, Dr. Winslow, those were both just excellent presentations, so incredibly thought-provoking. Let me ask each of you, what do you think have been the top challenges in collaborating? That seems like a theme for both of you, is the collaborating and conversing with partners. What have been the top challenges?
I'll go with it, okay. So, I think for me, it wasn't that hard. So I think the thing that gets people into trouble with collaborations is they don't ask. And I found, I decided to use in my position the power of poverty in getting the work done that I got done. That as I went to people and I said, I don't have resources, but I think you feel like this is important and I feel like it's important. And I found partners brought things to the table when they were asked, but you had to ask for help. And it's a great position to be in, actually, that I didn't realize until I actually got into this big leadership position and had limited resources, and found out that other people wanted me to be successful. I wanted them to be successful, and we had to leave our sort of pet projects on the side at the door and come in saying, we're going to agree on what our common ground is, and we're all going to stay focused on that until we get it done, and not sidetrack ourselves with all the other issues and concerns that can come to the table. So I think asking has been, and knowing who to ask is a bit of a challenge. Who needs to be at the table? I mentioned for House Bill 198, we went through 11 revisions of that, and finally the Legislative Services Commission said I couldn't come back anymore. And the reason I went through 11 revisions is people kept coming to the table saying, we want in on this too. And we heard about this and we didn't know you were doing this, and it's important to us. So that project started out in one part of the state, ended up in 4 parts of the state. We started focusing on the House of Medicine. The House of Nursing came and became very much involved. That could have derailed the whole thing potentially. Instead, we were able to get them to work together towards common goals. In fact, in that project, we mandated 4 of our demonstration sites be nurse practitioner-led practices, because I wanted to find out, are they better or worse or the same or what? And we had no data to support that. So we decided to make it more an investigative type effort rather than just limiting. So I've always been one to add and be willing to add others at the table in the conversation if they're coming with the right attitude. And what I found was everybody wanted what we wanted because they were all concerned about issues in population health, and they had no idea from their vantage point alone how to get there.
So I've learned a lot from my patients over these years. And as a young clinician, I remember thinking, oh, I know how to help people get better. I mean, I really do. I've studied for an extra 12 years, been to lots of countries, lived in other countries. And in the end, do you know what it's about? It's about asking, what matters to you? How can I help you? And just meeting them where they are. And I actually think that's the same conversation, just at a different table. What matters to you? And then, of course, that's how we get back to money. Remember the money that the folks wanted up front, but we wanted to do all the design and all this other process in between. In the end, that sustainability piece must be addressed on the front end. So if we can be more transparent, and that would be really helpful. And then the other piece is the time constraints need to be made public. So if we wait 5 years for enough collaboration, a few budget cycles have gone by, and then you don't have anything that you can really address because sometimes you do need a little bit of money to bring different focus. So I think that's very, very basic. The other piece has to do with group dynamics. I'd imagine that many of you have tried to accomplish things in large groups. 100 people. We are going to do guidelines. We're going to do something or another. Guess what happens? It always comes down to those 5 or 6 people, right? So part of this is acknowledging human behavior, group dynamics. If there can be a lot of listening and then some small group, like your planning committee here, put something on paper for others to react to get feedback by electronic and other means, that works. That absolutely works. So let's use what has worked. Let's make our timelines transparent, our processes transparent, and then make use of the parking lots that Dr. Winslow talked about so that we don't lose track of some of the issues.
Great, thank you. And I'd like to invite the audience to come up. We have microphones on either side of the room. And if you would kindly identify yourself and then ask your question.
Hi, Sandy Magnan from the Institute of Clinical Systems Improvement. Thank you for a wonderful presentation, and bringing that care delivery part together with the payment part is really challenging. I find that people, it's much more interesting collaborating around the care redesign, but collaborating around payment that you are able to do is tremendous. So I think any specific words of wisdom you might have in how you brought private payers together with the public payers would be one. And then my second question would be, do you have a dream, or maybe I should say a delusion, of getting to global budget payments in the future, moving from episodes to a global budget for populations, and how you might do that?
Let me start. I'll just start on the answer, and much more detail will be given by Mary. But I think what the state decided to do was demonstrate that this is possible by taking what they could leverage, that they had control over, which was 2.2 million Medicaid patients that we insure, and 500,000 state workers that we insure also. And we said, we're going to apply these principles, which sound, somewhat difficult to get your hands around. They're very conceptual. We're going to actually apply it to that population. So the first step that the state did was do what they were telling everyone else they should do by doing it with what they could control. Then they carried that forward and challenged the insurers to do the same thing, you see. And so now you got a little equity built up, and you put your neck out just a little bit, and it's not just you telling everyone what to do, but showing them what to do. And I think that was an important first step. Control what you can and make decisions with what you have the ability to make decisions on, but then bring the partners to the table and say, now we challenge you to do the same thing. By the way, we didn't go under doing it, right? Medicaid didn't go broke doing this, and our state workers are still insured. And actually, we've been able to demonstrate with that some real advances, and the other insurers now are challenged to do the same thing.
From my perspective, the process was fascinating because there's transparency and then there's partial transparency, and you can't start with pure transparency on day one because it's quite frightening in this kind of environment. So I think the key piece was being able to have leadership at the level of Director Moody and the Office of Health Transformation. I think that was absolutely crucial. So having our governor involved in this work was one of the linchpins to even being able to launch. The second piece was Medicaid being willing to invest in all of the data analytics to be able to share it then with all of the private payers in a way that was not frightening to us. It basically does show warts and all, where are we not doing well? And some of that is actually shocking to folks, but in the end, we have to start someplace. So that sort of helped muster up a little bit of courage. Then we gathered the clinicians who had to fight a little bit over data and what they meant and how accurate is it really. And what we're going for is not perfection, but good enough to improve. So sometimes we actually forget. We want total perfection. And to me, that's like scrapbooking. When are you ever done, right? You can always... And then the last piece is, we did not bring the financial officers of the institutions in until after those pieces were done, because we did not feel that we could navigate the conversation of what ideal clinical practice was if the folks who kept the books were there on the front end. Instead, what we said is, bring us your best clinical leaders, and we have nationally renowned leaders. Cleveland Clinic, the Ohio State University, Cincinnati, we have wonderful, wonderful academic institutions. So we started there with the design and then brought the finance folks in together. So it wasn't that we had favorite children. We brought public and private together. So that was actually part of the transparency and the process.
And I'll just add then that, one of the critical elements was having a level of trust where we could have these conversations. And we were dealing with a lot of other problems at the state level. Opiate prescribing was a huge issue. Infant mortality was mentioned. We've got, no short list of major problems. these people are accustomed to coming to the table and having conversations with us, and based on how we had interfaced with them, they were willing to come to the table with this. And, kind of illustrates that old adage, that, change is really exhilarating when it's done with you, and it's frightening when it's done to you. And people came to the table. We'd invite 2 or 3, and 10 would show up. And because they really, really saw, first of all, we were serious about change. It's going to happen, whether it's with you or without you. It's going to happen. They believe that. And then they moved resources to make sure that they were engaged in whatever the design was. And they knew they wouldn't necessarily own the product, but they did know that they'd be listened to, and then their input would be used to make it as good as possible.
Any thoughts about going to a global budget?
So that was my next piece. My boss is pretty aware that I'm not the one to talk about money because I always think it's simpler than it really is. I think we're at a point now, though, that as we launch this, we actually are collecting information to help inform how it is we need to build a global budget. So we actually are not there yet. I'm not sure if you disagree with that.
No, that's correct.
Good morning, Jeff Levy, Trust for America's Health. A really great presentation. I'm struck by your discussion of addressing the social needs of patients and how critical that is to achieving these outcomes. So I have sort of a practical question and then perhaps a larger question, more philosophical systems question. How are those connections made? So almost at the clinic level, how do people know what are appropriate social services, what is available? So how's that connection made between the healthcare system and the social services system? So that's the practical question. And then the larger sort of policy question is, and when you identify social service needs that are not, for which there are not services available, either because it's just not being provided or there's not enough capacity, where does the health system come in to close that gap?
So perhaps this would be a good time to talk about my example. Would that be okay with you? Okay. So thank you for that pragmatic question, because in the end it is about how do you get to action on the ground, right? So I'd like to give you the example related to infant mortality. So I think many of you are aware that Ohio does not fare well, particularly with disparate outcomes and infant mortality among our African American community. So this slide has a lot of wonderful color on it, again, back to my pediatric roots, but I point out the connection from science and evidence to how we get to an action plan. So it's important when we pick a priority that we actually look at where is there feasibility, evidence that there's a better path, interest from the top as well as from the ground, and a measurement system that actually can support it. So this population is of huge interest because we can check off everything on the list. So I have a little pie chart in terms of what goes into infant mortality. Preterm birth across the country is the single largest contributor to infant mortality, not the least component of which is the mothers are not in good health before they are ever pregnant. So there's this epigenetic nature of it. So we would be fooling ourselves if we think we can fix this, in one political cycle. However, we do understand a lot about what goes into preterm birth. It's an area where there actually are a number of clinical interventions that we cannot even take to scale in small communities, partly because we're butting up against couch surfing, not being able to find women, all the social determinants you talk about. The sleep-related deaths largely are preventable, so we've got to get the message out. In that other category are infections and violence and whatnot. So with the understanding of what goes into it, what is the measurement framework around which you can gather partners? So I have an attempt here at a life course measurement, core measurement system, adolescent well checks. I wrote 17P because progesterone took too much time, but definitely there's vaginal progesterone as well as one of the single best interventions for preterm birth if you can identify the women in advance. I put just one hospital measure in there with early elective deliveries. Really, it could have been your C-section rate, for example. And then I included postpartum. And all of those color-coded ones would be things that could help you in this preterm birth harm bucket. Safe sleep is color-coded to the others. And then this last one, the social determinants, I put under other. And the measurement system there, there's a little fight over, well, which measurements are more important? Is it about getting women out of high school? Is it about violence? Is it about employment? Is it about housing, transportation? You know, there are all these measures, and we actually don't have a single source of data. So it's a problem. So then we identify who our partners are, and they're in blue, but I have in the blue box here other partners. And the question to each of them would be, what can you do to help adolescents, you know, be seen so that we can have a conversation with them? And it's interesting over these decades. It used to be that those well checks in the office were about your growth and who are your friends and how's your family doing. And then it became the searching for folks with mental health issues and doing some cognitive behavioral therapy with the parents so that they could help more. And then, you know, you may or may not have time to ever get to the reproductive health conversation in your 20 or 30 minute, or some practices 10-minute visits. So the nature and the burden of the chronic conditions is certainly evident in well checks. So for every entity, you know, what can they do to help? If all of us did that, we actually could move the measures that were delineated. So in the social determinants bucket, since there are so many and we don't have a data source, how could we possibly address it? So in Ohio, what we've decided to do is to figure out how to get the message out about what we're trying to do. So I mentioned to you already our disparate outcomes. We actually put the exact numbers. How many babies are we talking about? In African American communities, 373. That gives us an infant mortality rate over 15%. Over 15% compared to our white babies at 6.3. The more recent numbers look better for both. But if we only did that, then we would miss 703. So we need a balanced approach to how we're actually going to peel back the layers of the onion. So that's the why. That gathers a lot of people. Then we have to show a path. How are we going to do this? So we describe preterm birth is a really big deal. So, you know, the calls to triage saying, you know, my belly hurts, and the answer is go away, that doesn't actually work for people, because how can you really identify, and then by the time the woman's already in labor, you've missed a lot of opportunities. So here, we have delineated a couple of measures that we think coalesce in multiple systems: adolescent well checks, postpartum visits, and then the cultural piece there means that for any measure that we do, we're going to measure for the population at large, but then we're also going to measure the African American community based on self-reported race and ethnicity from their Medicaid eligibility files. Then, after that, you can map it to the region you're trying to work at, right? So it could be an urban area in Cleveland, or it could be down in Cincinnati. And then I do mention sleep, and as well as the use of tobacco products to get there, and what the measurement system actually could be. So the new ICD-10 coding system that's coming has pretty much every diagnosis, and then every diagnosis in a smoker or in somebody who's had no prior care. And in some cases, some of the violence and other types of factors, actually there are codes, the ZZ codes. So now in the claims system, we can actually get a lot of the information that we seem to be unable to get from the variety of entities involved in social determinants. So what does this actually look like? We can be strategic about where we concentrate the efforts depending on what the goal is and who your not-for-profit is and what their missions are. So target the neighborhoods. In our budget, we actually have a proposal through Medicaid managed care that they must hire community or deploy. They don't have to hire them themselves. They can contract out to local health. Community health workers whose job it is to seek and find folks at risk and to remove barriers. That is their job. You can be a high school educated person, go to anywhere 2 to 4 month sort of program and actually be ready on the ground to help figure it out. Then the information is captured within the case management systems of the managed care plans, so we don't have to invest in an entirely separate data system that then nobody has access to because of the lack of transparency. So, you know, leveraging what we have within the program to get us to a different place is actually going to be really important. And we're intending to do public report outs, likely quarterly, with our infant mortality consortium, in conjunction with all of the partners at the table. So in brief, that's kind of drilling down to the neighborhood about how we actually might get there through the public health and Medicaid programs.
So that's a phenomenal example of how the clinical system and the public health system can be working together. But then there's also the social services part that can be a critical piece. So, for example, I don't know whether it applies in infant mortality, but broadly speaking, having stable housing is a real predictor of better health outcomes. And so I'm wondering where you are in the development of this model in making that kind of a link to truly, not public health, but truly social services. And how do you make that link? And where there is a gap, how do you bring people to the table to close that gap?
So I can just make a comment here quickly. So one of the issues right now is actually that we do not have the data about exactly what the needs are. What we have are a collection of anecdotes. So it's difficult for me to put a budget proposal on the table without the data to support it. One of the things that comes out of an effort like this is now we have a data collection tool so that I could go to the Director of Job and Family Services and say, for this population, women of reproductive age with average household size of X, I need X number of housing units located in these regions. And you could do the same thing by your other priority populations. So I think we're going to be talking about cardiovascular disease, major issue with diabetes and hypertension and the elderly as well. We haven't talked about it here, but we have parallel efforts related to moving folks out of institutions into home and community-based services. And so we see these as dovetailing so that the investments are in the communities where patients live. So we are in this early phase of collecting the data.
And so, I look at the top and the bottom of the equation. The top side is health and all policies, right? And you're familiar with that, and it's been around for a number of years. And I think people are now starting to understand what that means. And that was part of the reason the Office of Health Transformation was created, was to get everyone together. So no matter what agency you're in, you have some idea of what decisions in one are how they're going to impact what happens in others. So we have to, at the top level, have that communication happening so people understand the impact and the needs that cross over. But at the frontline level, if you go to the whole other end of the spectrum, and that's the clinician in the exam room with the patient, how do they get access to that information is probably a better question in some respects, because that's the interface directly with the patient on an individual level that we hope across the nation will change. And so that means if I'm seeing a child and they have a zip code address, that I can tell if that's a high lead level area, if that's an area that has low fluoride, if there's a lot of crime in that area, if there are housing problems there, if the air quality is terrible. All that data is already out there. It's just it doesn't get to the exam room where the person that is seeing the patient can use it. They can chase it down, but nobody's going to do that. So we have to make it very easy for the clinician to have the information that helps them in their decision support to make public health informed recommendations to patients who are coming in for traditional clinical care. That'll be the ultimate blending of the two that has to happen. But there's another problem with that, and that is none of the clinicians expect to do that or are trained to do that. So the other side and the partners we're bringing in are the academicians saying, if you guys don't get it, this is never going to happen. Because I've been engaged for 20 years in retraining doctors, and it's really hard. And they don't want to necessarily change what they're doing, and that's not so much different for nurses or PAs or others. So I'd much rather they come out with the wheels spinning already out of their training, ready to do what we need them to do with this perspective that's very different than what they're coming out with now. And that's why in that House Bill 198, we also put together an imperative for developing interprofessional education curriculum and curriculum reform, so we would change what our students are learning, and they'd come out demanding this kind of stuff instead of fighting us when we go to them and say, you need to consider social determinants of health, you need to consider environmental health issues. I mean, this is all news to the docs out there, but for the new ones, I'm hoping they'll say, of course, and if I'm not getting this information, I demand that I have that to do the job I need to do with my patients.
So to be more obvious about what Dr. Winslow said is we must change the way we are training clinicians and allied health personnel. We must change. We spend all this energy retraining when in fact we should change what happens in medical school and residency. So in many of the programs, they have a separate curriculum for the care of vulnerable populations. So how does that actually make sense to any of us? In Ohio, for all of the medical schools we have, a majority of clinicians will not see many Medicaid patients once they get out because their duty is done. Is that really what it's about? So is there opportunity around GME? I know this group has actually spoken about that. The one piece I want to mention, though, is with our community workers, we do have a little bit more built out. I think many of you are aware of ARC's Hub and Community Pathways model. We actually have a mobile app. It's an iPad, so that the community health workers can actually capture the data when they're actually out on the field. We've standardized billing and coding so that there is a way to pay for getting all the immunizations done, bringing somebody to care, addressing housing, and doing the appropriate referrals. So there is a little bit more detail that actually can help us actually get there. The payment mechanism, though, perhaps is clunky, and what I really need is I actually need a population-level regression analysis of the social determinant impact on healthcare expenditures, so that if I'm going to do value-based purchasing, could there be opportunity to risk adjust based on that, so that we've provided incentive for institutions to actually truly invest in some of those services. So that could be another way to actually look at the issue. It's perhaps a pretty big ask, but I could see how it could be useful.
Yeah, George Isham, Senior Fellow at the Health Partners Institute for Education and Research, and co-chair of the roundtable. First of all, I wanted to really comment on, Sarah, your introduction in terms of Secretary Burwell's recent announcement. I think that's incredibly important. Not only the blog that's available on the website, but the commentary in the New England Journal on January 26th. And then she refers to an article in the Journal of the American Medical Association by Kumar, Conway, and Tavener from May of 2014, where there's some details of payment strategy. And attached in the supplement to that, which is really inaccessible to people, which I recommend you get, is a table that lays out the framework for various payment reform. And category 4 in that table, if I'm recalling it correctly, is population-based payment. Also in the detail there, particularly of interest to this roundtable and the other partners beyond healthcare and public health, is the notion of moving toward incentives for improved population health, not only in the subpopulation sense, as healthcare often describes it, but in the general sense. And so I think there's, given the determination, the explicit nature of those goals, there's an opportunity for us to think about how that can be used more broadly in creating a common conversation. And then my second thing is a question. Just a tremendous example from Ohio, and the two of you are very articulate. Learned a lot from what you said. I know from the Buying Value project from work at the National Quality Forum that the fragmentation in terms of both measurement and incentives is on the governmental side between the states, as well as between the federal government and the states. And again, Secretary Burwell lays out some intent to create collaboratives to address that significant issue. So I'm curious about how your efforts align with your neighbors. Michigan, Indiana, I guess Kentucky, West Virginia, Pennsylvania, in relevant ways. How is it different in Ohio, and what would you need to use your, quote your phrase, Mary, measurement systems around which you can gather partners? Are there regional issues in your part of the country against which you're collaborating with your states that are different, say, than California or New Mexico, where I now live, or Minnesota, where I'm from?
So I'll just give one example to start with, and that's on this issue of opiate prescribing. And so we have worked very closely with our partner states, all of which are struggling with this issue, and brought them into communication and collaboration to the point where, you know, we have an OR system for looking at our prescription history for controlled substances, and the states around us do too. And so our prescription drug monitoring programs for all our contiguous states now share information across states, so people, especially on borders, can't go to one or the other and then escape identification and tracking. So that was just one example of a number of things we're doing now across state lines. We share the same problems in infant mortality. If you look at infant mortality and where is it located in the nation, you'll find Michigan, Indiana, Ohio. It's not Louisiana, Mississippi, all the places that we're used to looking at. The problem's in the Midwest. And so I might let Dr. Applegate talk a little bit about how they've tried to work together on that issue too.
HRSA's coin has been an interesting experience to me, but I think necessary. So oftentimes the states are entities unto themselves. So the Collaborative for Innovation and Improvement Network is a fascinating idea, although it is a volunteer activity. As we've tried to do this, we have struggled with stability in leadership, confusion about measurement, lack of understanding as to the framework and the process in moving forward, and folks have tended to want to do what they have already done. So in the end, I think we should be explicit about saying this is new work, and we're actually not just going to rebrand something that we already did 5 years ago, even if that's easier, because we are desperate. People are desperate to not have babies die, to not have death rates from stroke and heart attack vary so much. So it has been a challenge, and I think some of the fuzzy front end, as they like to talk about in improvement science, actually is a necessary piece of trying to get our ship in order. So hats off to HRSA for trying to get us together on a national effort and trying to learn from the efforts that preceded us.
Very good. And then I'll just do a shout out to CMMI showing real innovation by allowing us, when they selected Southwest Ohio, to include Northern Kentucky and part of Indiana in the project, because those were natural capture areas for patient care in that area. And so they allowed us to go over state lines and include those partners from other states in the effort that we were doing, so that we could do a true regional effort that does not have a state boundary to it. Patient care doesn't work that way, and so they were willing to be flexible in their definition and turn that around in a matter of weeks. So with that kind of flexibility and fluidity shown by national organizations to us, we figured like we can invent lots of great things because we're not restricted.
And I might add that the invitation to have Medicaid at the table, since I'm in Medicaid, is actually very, very useful. You know, to acknowledge that the Affordability Act is a game changer in terms of who the partners are is really, really important. And it was a surprise to me to find that in many states there's not a tight collaboration that I think actually needs to exist if we're going to get there.
Great. I'm just going to do a quick time check with folks. Our panel is scheduled to end at 10:30, and I now have 10:17, so I'm only mentioning that because I think the lines at the mics are maybe longer than we have the opportunity.
We can be shorter.
We gotta
Yes.
go fast.
Okay. Very
so,
good.
I think
Chop, chop.
we're on this side. Thanks.
I'll step it up. My name is Karen Armitage. I'm a pediatrician and public health physician from New Mexico. But this year, I'm a Robert Wood Johnson Health Policy Fellow. I have a very specific frontline question for you, being a veteran of many encounters with the most vulnerable rural and underserved populations as a public health physician. You mentioned that 40% of expenditures may be tied to social determinants of health. For the provider and the team seeing, for example, a 25-year-old mother with a 2-year-old and a newborn, with the reason for coming in, newborn check, and an ear infection. But the mom also reveals her partner is incarcerated, she lost her job when she took time off to have the baby, and she is having trouble with breastfeeding. How does your episode of care payment report, what metrics are you using to help that team to measure the cost of care in that patient's case?
So that's a great question. We have not started all of the pediatric topics. So the main one we have in this space is the initial perinatal one. But one of the things that we have grappled with is there a way to focus who actually gets a home visit and what the purpose of it is? So again, in this period of time moving forward with our community health workers and with the possibility of having more women in kind of centering or group care kinds of environments, we'd like to harness that social capital of helping women not be isolated to actually be able to move forward. So not a complete answer, but at least there's been some thought.
Thank you.
I'm trying to speed the group up, so.
Good morning, George Flores, California Endowment. Thank you for a great presentation. 2 questions relevant to our state. One is undocumented immigrants or people that are continuing without insurance coverage. Does this program have any opportunities or assets that apply to that population? And number 2, how do local public health departments look different? I don't know whether Terry would need to answer that, but does this have any specific changes or services or applications in local public health departments?
So a quick comment, and actually, Terry, we'd like to invite you to address some of that if you don't mind. We can only leverage the program for folks who are actually eligible for the program. So we recognize that safety net services from local health districts do not probably ever go to zero. So this is the reality on the ground. So you can't totally eliminate them. However, they could be focused and streamlined and actually work with the other entities perhaps better than they do currently. I don't know if you want to address that.
And the only other thing I'll say is we do have a tight network of free clinics around the state of Ohio with thousands of volunteers who every day see these people you're talking about who can't get into and aren't eligible for some of our set programs. That is a Band-Aid approach that we don't like at all, but we feel that that's at least identifying and bringing them into the system and allowing them then to connect, hopefully, into a more permanent solution to that.
But they don't get in the data capture in terms
They
of...
do not, well, there actually is a data capture within the free clinic model, so they have their own data, but it's not something that we use on a regular basis yet.
Thanks for letting me jump in. I'll be brief. So I think that if we look at the map, you'll see across the state, I think...
Terry, I'm sorry, could you identify yourself and
Oh,
where
sorry.
you're from? Thanks.
Terry Allen from the Cuyahoga County Health Department in Greater Cleveland. And I'm very proud there how folks did a fantastic job. So I would say that if you look at the map, Cuyahoga, Cleveland, Mahoning, Youngstown, Summit, Akron, Franklin, Columbus, Montgomery is Dayton, Hamilton, Cincinnati, you've got population centers that have a larger public health capacity based on where the hotspot data is, which I think if you look across the state and you look across public health nationally, there may be some uneven capacity, but it's going to be based on budget, need, and I think that in this particular case, I think given the areas where we're seeing the hotspots, the majority of them that are noted here, that the capacity for public health to be involved from a community health worker standpoint, home visiting, systems that may already be in place, for instance, in Cleveland that exist within the first 2 weeks of life. Connecting back from the tobacco end makes perfect sense. And there's a tremendous amount of capacity and opportunity, even with this new budget that was just released this week, that would expand those opportunities, particularly in high-need populations, African-American populations in the Cleveland area, as an instance. So I think that it matches well relative to this model here, but across the state it can be uneven. I think we need to lift all boats, and I'm hopeful that will happen in the process. Accreditation, I think, will assist in that regard.
And then I'll just end by shamelessly letting you know that our Association of Community Health Centers refuses no one based on their ability to pay. We now have 565,000 patients in 55 of our 88 counties that we provide care for on a regular basis, and they don't have to be on Medicaid or other coverage models. And many of those patients you talked about who fall through the cracks typically, they end up in our safety net clinics. And 73% of our patients are below 100% of the federal poverty level. 90% are below 200% of the federal poverty level. And that's why I transitioned over into being chief medical officer of that organization, was to in a more structured way, get at that population. And we do measure them very carefully with UDS measures as far as quality outcomes, cost measures, and others. So that is a very important part of our total healthcare delivery system.
Thank you.
Hello, Kathy Bazzi. I am the Chief Health Officer for the Dow Chemical Company and also a member of the Roundtable from your neighboring state of Michigan. First of all, I want to applaud the example. It's terrific. And mindful of the time, I'll be only giving you one of my many questions here. So as we're trying to use this as an example, this story is illustrative for the Roundtable and for others to learn from. And I was thinking about how did this journey get started in Ohio, and you began to talk about the governor and the governor's mandate that, if I heard the story correctly, that's part of the insticus for all of this happening in terms of the stimulation for you. But was this driven by sort of just crisis in budget that drove the governor, or was it through a lot of insight that had bubbled up about a believable alternative future and the merits of that. You know, how did this come together so that we can think about how to stimulate similar activities and leverage this to other communities, other counties, other states?
Yeah, well, all those things are true. I think it kind of illustrates the old statement, never waste a good crisis, you know. We were in a financial crisis, we were in a health crisis, we're facing lots of problems. And that actually opens people's minds better because, it's easy to stay comfortable and not change if things are going reasonably well around you. Well, we were in a very bad situation. So the governor had for years been developing plans of how he would like to run things differently because he had a strong history in Washington and had brought some of that perspective of budget balancing also back with him. So he had his own agenda, and he had surrounded himself with health people who were very knowledgeable and brought that into the equation. Then he also, though, saw that the need was there where people would probably actually be willing to make some change in what they're doing. And so he brought people on board that wanted change to happen. My question to him when he interviewed me was, are you serious, or do I need to go somewhere else to make change happen here? And he said, just fasten your seatbelts because we're going to take off on a ride like you've never been on before. And I said, great. If that holds true, I'm with you all the way because I'm really tired of things being the way that they are right now. The reason I personally got engaged was that my graduates, because I trained family practice residents for 22 years, they told me they loved the training. We did a tremendous job. I did integrate public health into their training in clinical medicine. And they said they went into practice and they couldn't do most of what I taught them to do. That was shocking to me. And they said, thanks for the education, but it doesn't work out there in the real world. So we all knew that change was needed from a lot of different directions. And what the governor's office did coming in was brought all that together, I think, at a time that was ripe for change because things were bad enough. And so in my talks that I do with the public, I always said to them, I spent the first 30 years of my life seeing what I could do with people that were in pain to try to help them with their suffering. And I said, now my job is to make all you people that have been too comfortable as uncomfortable as hell to go ahead and get you to change from where you are now to a better place. And that's always painful, changes. But people were ready to change because they were very unhappy with where we were.
Yeah. Let's not discount the competition with Michigan. We can do better. Great question. Thank you.
Hi.
Last question.
Okay, well, we have some questions from the web, and I'm going to read them quickly, and then you address what you think you can in the short time you have, and a lot of these maybe can be revisited later in the discussion later in the day. So we have a question from Katie Brewer. How are the acceptable and commendable costs defined and determined? Is it a national average or based on another formulary? And then a question from Erin. You mentioned schools, but didn't include them as a safety net, and wondered your thoughts on how schools could help identify those at risk as well as get messages out, especially if there are appropriate school nurse staffing. Seems this is a link in healthcare that is not being utilized as it could. Are there thoughts on how they could be included in the equation? And the last one I'll read is from Marissa. Where do you collect the measures that the providers agree to be rated on? I have found in working with awardees that often the EMR doesn't collect the data in a way that lends itself to useful analysis later. Have you adapted the EMR, deployed another system for data collection in parallel? Those are the questions.
Okay, how about if I give the snapshot to get through three of them? So the first question related to value-based purchasing and how do you draw that thresholding line? I specifically didn't talk about that because we allow each payer to decide where their line is. So that's a payer decision. Next question related to the schools on that cube of measurement and who's doing what. I only had room for 4 lines, but the role of the schools is huge and totally untapped as it relates to what health trajectory people may be on. So the fact that by law, children have to go to school, remember my thought was let's go to where the people are. We have huge capacity to be able to impact health, but it's very tied to political systems. So for example, in Ohio, we were unable to pass the required physical education requirement. We want people to be healthy, which means that they can move. And then in my practice, I loved the PE requirement because it told me who had esteem issues, and then they would show up for attention. So we have not harnessed what the schools can do. In Ohio, we are looking at what the school Medicaid program could look like. But I think those conversations are starting now, really, related to some of the legal concerns of sharing information that I referenced earlier. The last question was about the gaps and problems with measures. Currently, the measures related to claims and feeding that back to practitioners is ripe and ready for improvement. There are a number of multi-state work groups related to EHR-derived measures, and in our Cincinnati and Kentucky region, that actually is what we're using. But again, I think that process is perhaps in its toddlerhood rather than infancy.
So, as a quick recap, when we think about success related to payment reform, I'll just remind you of the successes that the IOM identified in integrating primary care and public health: shared goals, community engagement, aligned leadership, a focus on sustainability, and shared data and analysis. So I think those are themes that have resonated throughout this morning's panel. I'd like to ask you to join me in thanking Dr. Applegate and Dr. Winslow. Excellent.